All right. Hey, everybody. I am Dr. Josh Eloge. I'm a psychiatrist working at Rush, and I am really excited today to talk a little bit about bipolar disorder, specifically the depressed phase of bipolar disorder. I came across a paper that we're going to talk about today, and I thought, who could I nerd out a little bit with in this topic and get a little bit into the evidence? And the first name that came to mind was Dr. Aniruddha Deka, a friend of mine, dear friend of mine, also faculty at Rush. Ani, how are you?
I'm really well, Josh. Thanks for having me over here. Really excited about this. You know, um, we've had really interesting conversations about psychiatry in general, bipolar disorder, schizophrenia, medications, psychopharmacology. I think it's a shared interest for both of us. And I'm super excited to be here and have a discussion about bipolar depression.
Yeah, no, good. I'm excited. I'm glad you're excited because I'm excited too. Let's get into it.
Great.
So just a little bit further. So we're both at Rush. I'm the associate director of the Women's Board Depression Treatment Center, doing clinical trials, a lot of treatment-resistant depression, a few other things, and do a little bit of teaching. And then Ani is after his time away at Yale, getting super smart, smarter than he even was before. He's coming back and joining us on the CL service. He's the director of transplant psychiatry. And I just wanted to really quickly mention, as we're going to be talking about different medicines, some very new, some old. Neither Ani or I have any conflicts to disclose. So let's jump into it. So this is the paper. This came out in Lancet this month, hot off the press. Ink is still drying on my copy that I have here.
Lancet is great about these comparative efficacy and tolerability studies, right? Like with these meta-analysis, I think we've had several so far, including ones for schizophrenia as well as for acute mania. And this is a new one. This is the newest one, which is coming in for bipolar depression. Very
So
exciting.
important, right? Because they're good. They're really important clinically, and they're important for guiding guideline development that are obviously really important clinically. So these are really exciting to be able to review and kind of make some meaning out of them. So just to give a couple of quick headlines about this specific paper that we're going to be looking at, looked at randomized control trials with medications. So nothing psychotherapy here. This is all about the meds here. In bipolar 1, bipolar 2 depression, as well as bipolar NOS. They tried to cast a relatively wide net, specifically in the depressed pole of bipolar disorder. They came up with their inclusion exclusion criteria with 96 RCTs that included approximately 18,000 patients. And so this paper focused on efficacy, what works, confidence. Is there enough evidence to be sure that it works? How sure are we of what we get to see? And then they also looked at a couple of AEs or adverse events. And one of the more interesting ones, one of the kind of primary AEs that they were looking at was the risk of mania switch, obviously really important as we're thinking about different medications in bipolar illness.
I think that is really important, the way they have uh, uh, created the meta-analysis. What they've included, I think efficacy and tolerability is of course important, but there have been meta-analysis in the past. But what's new here in this study, one is of course it's a really large study which includes some of the newer medications, including lumateperone and cariprazine.
Mhm.
But also they are talking about the confidence of the evidence available, because I think with meta-analysis, specifically, you can get into that trouble where if you include all RCTs without a commentary on the confidence of the evidence, or what quality of evidence you have in those specific studies, it can get a little bit less. It can be a little bit less rigorous. So I think this study brings that in, that aspect of trying to really comment on the quality of evidence.
Yeah, it's a good point. So, Ani, so the way that they set this up, I think is interesting. Could you kind of dive in a little bit to how this meta-analysis works?
Yeah, so this is not just a general meta-analysis. What they tried to do was what's called a network meta-analysis. So what you can see here is this sort of like a web pattern in this figure, where you have different nodes, which are represented in red, and different lines, which are interconnecting different medications or interventions. The direct lines that you can see are essentially, they mean that there has been a direct comparison of two different interventions, whether it's a medication and a placebo or a medication and a medication. And the thickness of the line essentially means how many trials has actually been performed. And you will see that there's a lot of lines converging on the placebo arm, the placebo red dot, because most of the trials you'll find that there is a placebo arm in randomized controlled trials. And the size of the red dots also represent the number of participants who actually got that particular intervention. And again, unsurprisingly, you will find that the placebo dot is the largest in this case. And then again, what the difference in this is that what they try to do is they try to do indirect correlations. It's impossible to do sort of 100 trials, right? And for every single medication. So they try to infer certain efficacy or side effect patterns, even when there are indirect trials, when there aren't head-to-head trials.
Right, because it's really uncommon to get head-to-heads. Especially now, especially with branded products, like new drugs coming out, they really want to show separation from placebo. It's really difficult to get a study looking head to head. And so we are left with something like this to try to make these inferences of their comparison. But you're right, like almost everything goes to placebo, very few head to heads in this analysis.
Exactly. And that's a larger conversation about how drugs are approved and what is the incentive for manufacturers to do head-to-head trials.
Yeah. As well as what do we make of placebo responses, which are all too common in medicine in general, but especially in psychiatry.
Absolutely.
All right. So, this is important. Why is it important? Bipolar depression is tough. It's tough. It's tough because just diagnostically, when somebody comes to you, they're having a depressive episode, you think, okay, let me put you on SSRI or SNRI. But the risk, if they actually have bipolar underneath that, of inducing mania or inducing rapid cycling, these are things that we have to be cognizant of. But folks who have bipolar disorder, they spend 72% of their lives in the depressive phase. And we're not going to get into the specifics here, but like the economic burden, the functional impairment, like it's a tough disease. But it's an important one to treat. So getting more evidence here is an exciting prospect. This was we talked a little bit about point 2 here already with the meta-analysis, trying to figure out how do we put together all the data that we have here. And then Ani's point that I think is a really important one that I'm just reemphasizing here is that effectiveness or efficacy is important, but confidence really helps us. And the authors of this article make a point of saying, like, yes, we also looked at the efficacy, but some previous trials that did this, or meta-analyses, they didn't look at the confidence. And confidence is important for us as clinicians to know how sure we can be to go for that medicine, kind of in general, which we'll jump into next.
I think with every sort of randomized controlled trial, there is an element of subjectivity that comes in. Yes, p-values are super important. They help us make certain things objective, but there are certain things in trials which are not quite, cannot really be put into numbers. And I think that's where the grade evidence that they use in this case, like the grade category 1, 2, and 3, is called the grade framework to determine the level of evidence. That's where it comes into play. The expertise of the researchers, the expertise of the clinicians to really determine and synthesize how confident they can be about a specific trial.
On a gorgeous segue, bringing us right into the results here about how we the authors rather made these different distinctions of categories of what we can do when we combine the efficacy with the confidence. And so we'll zoom in a little bit here in a minute, but just to give you the big picture, this is the results that we come up with. So we've got essentially three categories. The first one, up at the top, you can see the blue dots up there. There's like 7 or so in that top one. That's going to be, these medicines are efficacious. They separated from placebo, and the confidence, there's enough studies. The studies are big enough, and the confidence intervals are essentially that line that stems out from that midpoint, and they're relatively tight there. So the confidence is good. So efficacy is good. Confidence is moderate, which in what we have here is about as good as we get. Nothing was perfect, but there is moderate was the best one. The second tier here is just below the blue. There's another 8 or 9 in that area. These are medicines that are trials that separated from placebo, but the confidence is not as tight as those top ones you can see. And so the certainty, the confidence of making sure that these definitely are efficacious was low to very low. And then the third category is the bottom 80%, which is these are not, there's no clear evidence that it separates from placebo. And a lot of these you can see the main point is not too far from the midline, which is what the placebo is, and the confidence intervals are relatively wide. Some of these are a little bit tighter and they still go over, but they're, essentially we can't really say with any confidence that these are better than what placebo are.
And I just want to add that when you have these horizontal lines for each of the interventions cross the vertical line, it essentially means that there isn't a statistical significance of the finding. So it's very interesting that we had a very short, like a very small sample of medications. It's in this case 7 medications or 7 formulations, which we could for sure say that they separated from placebo significantly in terms of efficacy. Also, as far as favoring placebo, the other sort of, if you can say, silver lining is that nothing really comprehensively favored placebo. It was more of placebo maybe or maybe not better or worse than this particular intervention for the rest of the about 80% of interventions that they looked at.
Yeah, good. Okay. All right, so these are the effective ones that had the moderate evidence. Let's just name them. Olanzapine with fluoxetine, quetiapine, olanzapine, lurasidone, lumateperone, cariprazine, and lamotrigine. We'll get into this a little bit more, but those are the ones that from this evidence really were like, these are the ones you got to go to. That second tier that we were talking about, these are some other ones that are interesting. And what we'll talk about this a little bit more, Ani, but what I think is really interesting is these are all like, ooh, maybe, but not like first line kind of stuff. This is stuff that esketamine, ooh, that'd be kind of cool. But yeah, the confident, like it's a pretty wide one. Pemaprexol, shout out to Jan Fawcett, our former chair, who pioneered these studies with pemaprexol back in the day. Small studies, but efficacious. Anyway, so these are the ones that are kind of like, that might be kind of nice. We'll see.
And I also want to point out that they sort of color coded, right? So you've got the one that stands out here is fluoxetine, right? Like that's the SSRI in certain terms like venlafaxine. But this one here, the color, the darker it is, less confidence they have. So they graded it as all of these medications or interventions as category 2, but within that category 2, they determined that the ones with a darker color had lower confidence compared to the lighter colors.
Mm-hmm. And then no difference. And this is a very long list. It's just the magnitude is interesting. There's a lot in here to talk about, Ani, but let's try to distill it down because there's plenty of things that would be interesting to talk about. Bupropion, or what else is in here? Just the SSRI trials anyway. But before we jump into the exciting stuff, so these meta-analyses are really good for big picture questions, right? And this is important, I think, to mention. Like, as clinicians, we get into the details with our patients and try to tailor what the treatment is for the person in front of us. And so there's nothing here about subtypes, like bipolar disorder with anxious distress, or with the depressive phase, maybe with the atypical features. We don't know like those specific parts or predominant, cognitive problems. We don't have that. And so it's important to recognize this is big picture kind of stuff. Also, there was no treatment resistance. They excluded people who had maybe failed a couple trials before of something. So this is really looking at probably first line, haven't really done anything. So important to think about that for what patient you're considering. And then it's not specific to bipolar 1, not specific to bipolar 2. This is kind of a bigger, wider net.
Yeah, I think these are the caveats that we have to keep in mind. I mean, for all intents and purposes, meta-analysis is considered to be the best form of scientific evidence. But I think we definitely should keep these things in mind, because the meta-analysis is as good as the sum of its components. And a lot of times, the trials may not be particularly rigorous, and they may not measure the same thing when you're combining it for the purpose of meta-analysis. So those are the big caveats. But having said that, I think this is a very important article, very important accumulation and synthesis of data. And let's get into it, Josh.
Let's do it. Okay, the first one. I'm excited about this one. Some of these negative ones. Aripiprazole, ziprasidone. I can't tell you how many times I have seen somebody who come in for bipolar depression. I say, let's do lumateperone, let's do cariprazine, let's do something with evidence. And the insurance says, what about something cheaper? And the ones they list in this study show that they are not going to work, that we don't have a lot of evidence. So I don't know if you're listening, insurance companies, but if you are, please stop denying my prior authorizations and telling me to do something that isn't going to work. And so I'm looking forward to sending in this paper. I don't think it's going to work, but maybe. But this was enlightening to me.
Yeah, no, absolutely. I think I think every psychiatrist or psychiatric practitioner who's listening to this, they must have had a similar experience where the first thing that is recommended, and I am not sure where that recommendation comes from for bipolar depression, is Abilify or aripiprazole, right? But I think thus far we've had a lot of synthesis of evidence, which has looked at aripiprazole specifically for bipolar depression. And I think it's important to make a point that we're talking about bipolar depression. There are different phases of bipolar disorder, but when we're talking about bipolar depression, which affects most people and for the longest duration of their illness time, there's not been good evidence to show that aripiprazole makes any difference as far as bipolar depression symptoms are concerned. However, as clinicians, we still have to go through that hurdle of where insurance companies keep telling you that you should try aripiprazole. And that's a really good point. A couple of other medications that sort of were no clear difference versus negative. Other antipsychotics, what we second generation antipsychotics that we often would think about. One of them was ziprasidone, and if you look at it here in this slide, it was actually a big. A lot of these trials are small, right? Like got 100 patients, but this one had like 4 trials with a total accumulation of 674 patients, and it just it did not separate enough to make a resounding sort of recommendation to say that ziprasidone may be particularly beneficial. And then again, to my surprise, actually, was risperidone. I think the one that shows up in this slide is the risperidone plus paroxetine, but I think there was also which was probably cut off from here, but there was a few trials of risperidone by itself, which did not separate. And in my practice, I've often considered risperidone because of insurance issues, oftentimes, to be honest,
Yeah.
where you feel like risperidone is going to be covered. It's a tried and tested medication. It's been there forever. There's not going to be a lot of hurdles. But this evidence, what it tells me is that these are small trials for risperidone. There's not been a lot of trials. I think there is like one trial for risperidone plus paroxetine and one trial, or maybe at max two trials of just risperidone looking at bipolar depression. And it failed to convincingly separate. So that might be telling us something, Josh.
Yeah. No, I think so. It does, yeah. And the confidence of a lot of these agents that are down here is not going to get any better, right? Like these are all now generic, which is why insurance is pushing us to use them. But
Yeah.
it's not like I don't see probably anytime soon that we're going to get a lot more studies like really going forward and trying to make this argument, right? So yeah, this is kind of what we are left with at this point, and I don't know if we're going to get much more data to kind of sway what this meta-analysis is trying to say.
But again, hey, insurance companies, if you're listening to us, not all antipsychotics are equal. They are
Mm,
very, very
mm,
different. They are
mm,
not equal.
mm. Get him on it. Get him. All right, number two. Lithium. Oh, I
This is
love
the big
lithium.
one.
I love it, and
Yeah,
this bummed me out.
yeah,
I
yeah.
mean, it's a gold standard, been around forever. Legends continue to use lithium, and it just feels like, yeah, if I'm going to be a real psychiatrist, I got to get lithium out there, right?
Yeah.
But this study, it didn't separate, and I mean, 300 about 300 people in those studies, like the confidence is there relatively,
It's
maybe there could be
number
more.
5 if you're looking at it on the slide. It's number 5
Like,
from the top.
yeah, and so it trended in a positive value, in a positive direction, but didn't ultimately separate. And so I don't know, I kind of got lost about what do I do then with this, so the way that I've come to think about this, Ani, and I don't know if this is what you agree with. We're talking about the depressed phase, right? And we're talking about maybe first line agents. And there's been a trend in the past 15, 20 years in bipolar disorder to prescribe more antipsychotics in general and less
Oh.
with lithium, with anti-epileptic drugs in general. And this is kind of making me think like, okay, maybe, yeah, in the depressive phase, maybe that's not where I should be using the lithium as much. And maybe it's more relapse prevention for the manic phase, manic treatment, in that phase of the illness, more kind of downstream, or maybe with a certain level of treatment resistance is when I should ultimately beginning to lithium. But that's what it kind of made sense of this. What do you take away from this?
No, I think I agree with you about this. It sort of redefines, or at least tries to redefine, the role of lithium, right? Like it's been the tried and trusted medication. When you think about bipolar disorder, you immediately think about lithium. Not just for psychiatrists, for society in general, lithium is
Mm,
intrinsically related to bipolar disorder. But I think the other thing to consider here is a larger conversation, which I think you touched on: bipolar 1 versus bipolar 2. Um, so yes, we have a tendency of clumping everything together as bipolar disorder, but are bipolar 1 and bipolar 2 disorders really the same entity from a very pathophysiological standpoint? Are they the same, or is there any difference in it? Um, what do you think, Josh?
I know that's such a good point. I'm glad you brought up the pathophysiologically of the phenomenology in front of you, right? Because yeah, that does dictate it a bit. And getting back to insurance in a certain way, if you have somebody with bipolar two, and you want to start them on something, like your options really are pretty limited for that specific indication. If you're trying to stay on label, evidence-wise, maybe something different. But when you're trying to stay on label for what's been approved, your
Yeah,
options are limited, and and that might be more just a paucity of studies looking at bipolar 2 specifically relative to some people who went after that indication, right?
I
And so,
completely agree. I think like we need more studies separating bipolar 1 and bipolar 2. We need better diagnostics, honestly, to figure out. And it's hard. Like bipolar disorder is the hardest thing to diagnose to begin with. And to subdiagnose is even harder. But I think
Mhm.
for appropriate trials to give us more information, I think it becomes important because it reminds me, like this study and the talk about bipolar 2 reminds me of this classical things that we learned about, right? Where does lithium work the best? Is the
Mhm.
euphoric mania, right? And when we think about euphoric mania, like euphoric as in like very huge personalities laughing, it's like the classic mania that you think about, right? Like you're running all over the place, you've got tons of energy, you're doing things. That's where lithium works the best, and that's what's classically been taught. And when you think about that picture, immediately there is no doubt in your mind that it's bipolar 1, right? So I think that sort of brings to my mind, are we missing something here? I think bipolar 2 is an important diagnosis, but I think it is important to make the diagnosis appropriately, whether it's bipolar 1 or 2. I think it's important to make that diagnosis.
That's a good point. And these are RCTs, so you don't maybe necessarily think that they're going to be much of the treatment decisions in here. But something else I kind of
Yeah.
think about is like, if I'm a clinician, I've had somebody who really, really sick, has had these clear manic episodes, and like they're kind of risky. I'm probably jumping to lithium sooner than I am maybe something else, right? And so maybe the RCTs, we get away from that, but I think it's important in our clinical minds about where do we place the lithium, and I think we often do reach for it when the severity of the illness maybe is more prominent, and we really want to like rely on our gold standard of treatment.
I think the takeaway for me from this is, yes, this did not show a perfect sort of improvement or a statistically significant improvement with lithium. But if you're convinced as a psychiatrist or a psychiatric practitioner, you're convinced that this is bipolar 1 without a doubt, and you're seeing actual manic episodes, and you're not like retrospectively diagnosing hypomania, or you're trying to diagnose bipolar disorder from depressive episodes, uh, and you have seen firsthand a manic episode, I think lithium, we can, I mean, despite what the study says, we cannot recommend against using lithium. Would you agree,
Yeah,
Josh?
no, I think so, and I am resisting going on the tangent of retrospective hypomania diagnosis.
Right. Yeah.
But
Huge.
I'm with you. I think
Another
we're on
topic.
the same
Yeah.
page. Okay, for lithium, you didn't shine too brightly for this specific subset, but I think we still have an idea of where we would put that in our clinical practice. All right, let's jump to the next one. Okay, so in addition, we talked a lot about kind of the individual drugs and the studies and evidence that we had, and then another step that the authors did here was put studies into classes of drugs or combinations, and then kind of lumped them together and see if there was something that shone through when they looked at the data a little bit differently instead of the specific individual molecules or individual combinations. And this page here is looking at that primary outcome, like what helps with depression. And then the second one is kind of the primary scary thing that we think about with treatment for bipolar illness is, do we induce mania?
Essentially trying to reduce the noise, right? That's what they're trying to do.
Yeah,
They kind of,
I think that's fair. Yeah. And
yeah.
so again, same forest plot idea. We got
Uh-huh.
placebo at 0. We got their confidence intervals. We've got, are you better than placebo or not as good as placebo? And both the positive outcomes, the efficacy outcomes, and the safety outcomes. And this was jarring to me. This might be the biggest part that kind of shocked me. Was antipsychotic plus antidepressant appeared to be the most efficacious of all of the options here. And then um, the role of antidepressants in bipolar disorder is incredibly controversial, and that might be another tangent that we need to tread lightly here. But there's something here too, because even as a class of antidepressants by themselves, 700 participants in this top page, that also was efficacious and separated, even better than anti-epileptics and our poor boy lithium. I mean, really fascinating in that part.
Josh,
Um,
I'm resisting the temptation to jump back into bipolar 1 versus 2 in this case.
And I maybe to keep us on track, we should recognize that these are RCTs. These are in the acute phase of depression. These are by and large short-term studies, right? And
Yes.
so when we're talking about efficacy and we're talking about mania switch, we need to recognize that a lot of these, I'm trying to remember, they tried to get most of them to be the primary endpoint around 4 to 8 weeks. I can't remember
Yeah,
exactly what it was,
I think it
but
was
but
about 8 weeks from what I remember. Yep.
but in the
It's a
grand
very
scheme of
short
things,
duration.
it's
Very
very
short
short
duration.
duration, right?
Very
And
short
when you're
duration.
looking at safety, it's tough, especially for the course of the illness, destabilizing the things that we worry about with antidepressants. 8 weeks really isn't enough to be sure, uh, to really even be very confident. But anyway, I digress. So let me jump into the mania switch real quick on you, and then I want to hear what you're
Yeah.
excited to talk about. For that, with the caveat of it being short term, the antidepressants leaned toward being a worse risk for mania switch, but didn't really completely separate. Again, maybe because of from placebo, maybe again because of the short duration, probably because of short duration, but it didn't. It wasn't as glaringly scary as I guess I was anticipating seeing.
Yeah, no, I think these are a little bit surprising, but also in certain aspects not surprising. Like for depressive symptoms, I think it is surprising that when you add on, yes, it is not statistically significant. The difference is not statistically significant. I don't want to say that actually antipsychotic plus antidepressant is significantly better than just using antipsychotics in depressive symptoms, but there is a signal which says that when you use an antidepressant, and it sort of bears out not just from the class effect, but also if you look at the 7 drugs, separate drugs, the one that performed the best was olanzapine plus fluoxetine, right? It wasn't just the olanzapine. So there
Yeah,
is a pattern that we are seeing here, that combination of an antipsychotic with an antidepressant perhaps may benefit most people. I think going back to bipolar 2, etc., I think I start thinking about uh, are we giving that additional like for the folks who are bipolar, who have a bipolar 2 diagnosis, a legitimate bipolar 2 diagnosis versus a bipolar 1, are we causing something, are we conferring certain additional benefit by adding an antidepressant in those cases compared to just a bipolar 1 disorder? Now the mania switch, I think, to me, this actually is something which is reassuring, right? Like we are always afraid of using antidepressants when somebody has a bipolar disorder. I think the big thing with the mania switch, I think one of the slides we skipped was out of all the medications, most of the medications, like separate medications, individual medications, did not separate out from placebo as far as switching from mania was concerned. It was only quetiapine or Seroquel, which reduced the risk of cycling to mania compared to placebo. So it sounds like for most patients with a bipolar disorder, you you don't you don't run a high risk of causing or cycling somebody into mania because you're using an antidepressant compared to placebo. And that's what this is telling us. But again, I think I want to go back to Josh's point about these are 8 at max, like 12-week studies, and bipolar
yeah.
disorder is a lifelong illness. So it's hard to really say with confidence that you're not going to, if you do an unopposed antidepressant, that means you're just prescribing antidepressants without using an antipsychotic, that you would not increase the risk of cycling into or switching into mania or hypomania in this case. What I'm trying to distill this information is as follows, is that if you have somebody with depression, like most of the time, which is most of our patients with bipolar disorder spending their time in depression,
Mhm.
and you're trying an antipsychotic, but you're not getting uh, enough out of it as far as the depressive symptoms are concerned, As long as you have an antipsychotic on board, and in some studies which have shown as mood stabilizers in general on board, it may be worthwhile to use an additional antidepressant. Because if you have a coverage of mood stabilization with either an antipsychotic or a traditional mood stabilizer like lithium or valproate, the risk of cycling into mania diminishes further. And this gives me more hope because even unopposed antidepressants did not separate. Caveat, short duration, but it did not separate from placebo, unopposed antidepressants in cases of bipolar disorder. So if you have a mood stabilizer, antipsychotic, plus an antidepressant, you might further reduce the risk of cycling into mania and may, and this is hard to tell, but may confer some benefit, especially in your treatment-resistant folks who are suffering from a lot of depression.
That's kind of where I put it too, Ani. I think I'm with you. Like, if you're not getting enough first line, then maybe we could start augmenting with those antidepressants. It also makes me think a little bit about the psychopharm of making these distinctions. Like, obviously, there's a little bit of overlap here. Like some antipsychotics, like lumateperone, is a relatively potent serotonergic reuptake inhibitor. So is it really categorically completely different? That's kind of interesting. Same with quetiapine's relatively serotonergic, ziprasidone, who didn't separate, but is a potent norepinephrine reuptake inhibitor. So, I can appreciate us putting them in these categories, but it does reduce it a little bit, where there's still some nuance between, like to your point from earlier, like not all antipsychotics are the same.
Agree, completely agree.
Yeah. Okay. So let's those are the three major takeaways, but there's still so much in this paper. So can we jump to a couple more maybe things?
Let's do it, Josh. Let's do it.
All right. Ani, take the wheel.
All right. So adverse effects, right? They looked at a lot of adverse effects. And that's a huge thing about antipsychotics, right? I mean, out of the 7 medications that we have, which this paper unequivocally said that separated from placebo in terms of both in terms of response to depressive symptoms, there was only one which was not an antipsychotic, which was lamotrigine. The rest of them had some kind of an antipsychotic, right? So adverse effects of antipsychotic: weight gain. You have worries about EPS, extrapyramidal symptoms. You have worries about akathisia. As a CL psychiatrist, the one question that I get asked about is QTC prolongation, right? That's the bane of the CL psychiatrist. So in that respect, this study is something that I can it gives me hope, gives me reason to recommend antipsychotics in patients who have comorbid medical illness, they have cardiac risk factors, but they also need some help, whether it's delirium, whether it's psychosis, numerous other conditions where it might be appropriate to use certain medications, and we want to use them safely, but also with the evidence to justify that these should be used and these should not be harmful. So this gives me a lot of hope because when you look at the QTC prolongation, none of the drugs was associated with a clearly increased risk of QTC prolongation compared to placebo. The interesting point here was, like, within the drugs, olanzapine actually had lower QTC prolongation compared to significantly lower QTC prolongation compared to Seroquel. And those are the two common ones that we use in the CL setting, right? And even when you look at the actual number, because again, QTC, what does that mean, right? Like the risk of QTC prolongation, that doesn't mean anything. You want to look at the number, right? Like, what is the milliseconds of prolongation of QTC? Usually, in my mind, might not be guided by guidelines. In my mind, the number is 500, right? Like a general, when you're just looking at a general person without taking into account other comorbid medical conditions, you're thinking about 500. And anything like beyond like, 10 or 15 milliseconds, you start worrying about it. So what did this study find? It found like for olanzapine and for quetiapine, there was like the range was about 2.32 milliseconds or minus 1.55 milliseconds. So at most, it was 2 milliseconds, or if you want to stretch it, 3 milliseconds prolongation of QTC. If somebody is 500 and they increase it to further, I add on an antipsychotic and increases to 3 milliseconds. I'm not that worried about it from a clinical perspective. But again, I think this gives me reassurance and hope. But again, a couple of things we had to keep in mind is usually QTC prolongation is a cumulative effect. It may not be just your antipsychotic that you're prescribing. It could be various other medications that are being prescribed for psychiatric or non-psychiatric reasons, which can add to the QTC prolongation risk. But overall, this does abate some of the concerns about QTC prolongation. And this is a big study. And I don't want to extrapolate it to every type of patient, but at least for patients with bipolar disorder, I think this is an important consideration to understand that perhaps in this subset of population, there is limited QTC prolongation.
Yeah, I think that's a really important point. I'm going to be having this paper saved in my Cover My Meds, and you're going to have it in your white coat when you're rounding on CL.
Absolutely. I mean, I completely intend to do that. I can just pull it out, right? Like, here you go.
Yeah. I think the other adverse event that stuck out to me was the weight gain, right? If you look at those
Yes.
top seven, olanzapine plus fluoxetine, olanzapine, Seroquel, these are some heavy hitters for weight gain. And I have, I mean, sometimes folks want to gain a little bit of weight, but by and large, that one is tough to sell. We get some lumateperone and cariprazine, and certainly lamotrigine. These are all relatively benign in terms of their weight gain, which was kind of reassuring. But the part that I thought was kind of interesting is that um, the olanzapine plus fluoxetine and the olanzapine, they both were, pretty, even more so than just the quetiapine was. And I always thought that those, in my mind, kind of had a similar risk for the weight gain, but it did show that the olanzapine plus fluoxetine and the olanzapine alone really did separate further for the weight gain relative to the Seroquel, making me feel a little bit more uh, open to using Seroquel a little bit more in my clinical practice, just because that's often why I tend to shy away from it. The exciting news that if you want to jump in on this patent with me, Ani, is I think Lybalvi plus fluoxetine I think is going to be like our moneymaker here if we're thinking about developing something based on what this study pulled away for us with weight gain.
Yes, I am definitely in, Josh. But I think the other thing that stood out to me as far as weight gain is concerned, I'm just pulling it up, just make sure that I am correct about it when I'm talking about
Mhm.
it. It's of course like number one is like you have lamotrigine, which the effect size was lower than the other antipsychotics, but it was considered to be weight neutral. So it's the other medication which seems to be safer when you're worried about that. But the other thing that popped up was lurazidone. It did not
Mm.
really it's been, we've learned, like in my mind it's like lorazepam and ziprasidone. For a lot of folks it was Abilify, aripiprazole, which was weight neutral, but it's really not. We've had several studies that have shown that aripiprazole is not weight neutral. But even in like 8-week trials, you're actually seeing a clinically significant or a statistically significant increase from baseline of more than 7 kgs. I think that's what they determined as for lurazidone, which often in my practice and in general, the recommendation has been lurazidone may not be as bad for weight gain, and that's a little bit disappointing when you look at it.
Yeah. Yeah, so just to give the specific numbers here, so I have it right here, and I think it's an important point. Weight gain of greater than 7% relative to baseline, and the risk. So the percentage of people who had met that 7% increase. For olanzapine and fluoxetine, 30.3%. For olanzapine alone, 28.4%. These are big numbers, but then a huge drop. And the next one, lorazepam, 5.4%.
Yeah.
And then quetiapine is below that at 3.5%, which is not what that was a little confusing. I'm still trying to wrap my mind around that. And then it continues to drop, criprazine at 3.1. And then I guess that's, oh, and then lumateperone and lamotrigine essentially like didn't separate, didn't seem to
Yeah.
have any different risk.
Yeah. So like
Yeah.
just to kind of take home the point, it seems like olanzapine is a little bit different in terms of weight gain, right?
Yeah. 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 But also the efficacy is there. I don't know. It's tough. It's a
It's a tough
tough
one.
ask
It's
for a
a risk
patient to
benefit
say this one's the one that
analysis.
works, but it's gonna, yeah, exactly.
Yeah, yeah. Okay.
Yeah. So Ani, tell me a little bit about what you're gonna make with AEDs, because this is
Ugh,
also really interesting.
with the adverse effects or
No,
oh
the
for
A
the
the
80s for the yeah.
yeah.
So this is super interesting because you had one AED. In that too, if you talk to a neurologist, it's not like the best AED that they would go for,
Mm,
lamotrigine, which
hmm.
seemed to really, and when we're talking about AEDs, we're talking about anti-epileptic drugs. So lamotrigine was the only anti-epileptic which seemed to show a difference as far as reduction in the symptoms of bipolar depression. Um, and traditionally, apart from lithium, what have been the medications that we have used before second generation antipsychotics came in? It was valproate, which is Depakote, right? It was carbamazepine, Tegretol, it was trileptal. It was those kind of medications, which are all anti-epileptic medications. But in this meta-analysis, what we're seeing is um, apart from lamotrigine, none of the other anti-epileptics, including all of these I mentioned, and Keppra, which is levetiracetam, uh, did not really demonstrate a difference as far as improving symptoms of depression and bipolar disorder is concerned. So what does that mean for us? I think um, in my mind, I'm trying to think about bipolar. Again, it's a very complex pathology, right? It's not a single syndrome. It's a syndrome of it could be a syndrome of mania or hypomania. It could be a syndrome of depressive symptoms. It could be a syndrome of just residual or maintenance symptoms, or just maintenance that you live with. So in my mind, I'm going to trials and I'm thinking, like most of the AEDs, apart from lamotrigine, perhaps does not have a lot of benefit in the depressive phase where patients are mostly symptomatic. 76% of patients when they're symptomatic, live in the depressive phase when they have a bipolar disorder. So apart from maybe quelling acute mania, is there a role for these anti-epileptics, especially when we are having more and more sophisticated second generation antipsychotics, which seem to, at least from the trials that we're seeing, work in each or at least multiple phases of this disorder that we're dealing with?
Yeah, I'm with you. I don't think that I'm saying we don't do AEDs in bipolar disorder, but it definitely is down a ways. And I'm looking for a particular patient, maybe a rapid cycler, where there's evidence for valproic acid, or maybe for somebody who has a co-occurring seizure disorder, or like there's it definitely needs to, in my mind, kind of subset not just the patient, but also the phase of the illness, like the decreasing the risk for future episodes once you get them back into euthymia, decreasing the risk if they tend to be pretty quick to fall into mania with one or two sleepless nights. Maybe that's somebody where I'm thinking a little bit more of like a Depakote or something there. But yeah, for acute bipolar depression, first line treatments, I guess lamotrigine's there, but I mean it's just barely separated too, and like they worked
Yeah.
hard, like that. It was so
Yeah.
tight, just
It was tight.
barely to the right side of the placebo.
And the
So I
effect
don't even
size
know if I'm
was
necessarily going there.
lower than the other medications that the
That's
other
right.
seven, six that were approved, or they've found a significant difference. And I think, with these with the AEDs, um, I agree with you. Like subset of populations, right? You might continue with these, but I think this is becoming more and more clear as we talk about bipolar disorder. Is that the old view of that? What we see is like, oh, somebody comes in mania, we admit them in the hospital, they get better on, say, valproate or carbamazepine, and they are continued on the valproate or carbamazepine. And
Yeah,
maybe there is time to start rethinking that approach, because the phases of mania, or the phases of rather bipolar disorder,
yeah.
are very different. So somebody who was in the throes of acute mania might benefit from an anti-epileptic, but does that remain the same when they're out of the manic episode or hypomanic episode, and they're now in a completely different state of the bipolar disorder semiology?
Yeah. Uh, yeah. I mean, you're absolutely right. Like it's almost like a different disorder depending on what phase you're in, a
Yeah.
different algorithm. I completely agree. Yeah. Okay. Supplements. You wanted to bring up a couple things here.
Yeah.
There are a lot of them. A
Yo,
lot of
there's so
interesting
many.
ones.
So this is like a wonderful part of this study that they did. They looked at like pretty much everything, right?
Yeah,
They
yeah.
looked at carnitine, inositol, SAM, what is it? S-adenosyl methionine? Is that how you say
You
it?
know, I trust you fully with that one.
Methionine. Well, we're gonna call it Sam. That's what we're gonna call it, right? Sam. Yeah. Omega-3, and I'm not gonna butcher the spelling of this, but it's essentially coenzyme Q. So I think there is a lot of movement, especially when you're talking about integrative medicine, right? Like a holistic medicine, where folks don't want to, and understandably so, because we talked about the side effects of antipsychotics, and they're not very benign.
Yeah.
I mean, most people from bipolar disorder, their mortality is from, first of all, their lifespan is reduced by about 10 years. And the mortality is from cardiovascular illnesses. And what's causing cardiovascular illnesses in a lot of these cases? Antipsychotics. So it is very important and very appealing to think about certain supplements, right? Like omega-3 fatty acid. You can think about coenzyme Q, all of these supplements. Or is there any role of these? Unfortunately, out of the 7 that this article full-throatedly sort of vouch for in their analysis, there wasn't a supplement, but we would be remiss if we don't say that out of the category 2s, where it's like separated, but
Hmm.
confidence was low, omega-3 and coenzyme Q seem to separate from placebo as far as reduction of the depressive symptoms are concerned. I wonder if these are these should be some things that psychiatrists should more frequently talk about, at least as augmentation agents, or um, when you're trying to achieve that golden goal of complete remission of symptoms. You're getting response, you're getting improvement, but you're not having full remission of symptoms, especially of depression. Are these worthwhile to talk about, especially the omega-3 and the coenzyme Q?
Yeah, that's a good point. I'm with you. I don't remember, I guess I didn't look too tightly, but I'm trying to remember if I saw too much in terms of negative outcomes with some of these.
Most of the negative
Uh,
outcomes, from what I understand, was looked at for the antipsychotics for obvious
Yeah,
reasons.
like
Most of the studies are
aimed
in.
at those, like the weight
Yeah,
gain, the
yeah,
sedation, EPS, activity. Yeah, exactly.
yeah,
So I agree. Like maybe a more comprehensive view would be able to integrate these. And this is important clinically because we get asked, I get asked a lot, I'm sure you do too, Ani, about like, well, can I'm really feeling crummy. Can I also take SAM? Like, can I also take vitamin? Is that okay? And by and large, it's like, well, as long as there's not any real like interactions from like a SIP 450 perspective, like I tend to be pretty like, okay, yeah, maybe. I mean, we don't have any, and I think this supports it. Like, we don't have any reason
yeah,
to say no. Like, it's not clearly poor or worse than placebo, like increasing a negative risk. And AEs aren't really giving us too much to say no. So it's kind of like yeah, maybe, sure. I mean, we're, as the clinician, we're stuck when there's not a lot of evidence to be like, woo,
to
maybe.
recommend
But
against, right? To caution people, right? Like we don't have that evidence to caution people against using it. And I think this adds on to that stance that you're taking, Josh, right? Like maybe, it's as long as it fits with your lifestyle and it's not interacting with other medications that are being prescribed for various reasons, it's fairly benign. And I think that evidence, sort of stronger for omega-3 and the coenzyme Q. And I think in that case, I think that brings to my mind certain dietary recommendations that people have,
yeah,
right?
yeah,
So the
yeah,
omega-3 fish, seafood is usually rich in omega-3. So those are bigger parts of treatment of bipolar disorder.
yeah,
Obviously, we still, as psychiatrists, as physicians, when we're treating a very acute illness, we must go with or recommend what has the most evidence. But when these things are brought up, I think this is actually in support of some
yeah.
of the considerations or lifestyle choices that patients might have. And I have no qualms about supporting that.
Yeah, and it's a good bridge for us as clinicians to support people with what their values are, and maybe even when the topic of supplement is brought up, to broaden in our own minds, like, oh yeah, it's not just the Seroquel. Like, I also need you to be thinking about diet and exercise, and like keeping it kind of in a holistic frame. And I think that's a good reminder to segue into that.
Absolutely, Josh.
Um, all right. Hey, listen, Ani, that was a lot of fun.
This
I
is
really
great.
appreciate you hanging
Yeah.
out and talking about this. I learned a lot reading this and just hearing like just wisdom after nugget come out of your mouth. And this was really great. Thank you so much for doing this with me.
No, this was amazing. I hope, this was a fun experience for everyone, just to kind of go through this article, this meta-analysis, not just go through this article, but also just like talk about what does this mean for our practice? How can we implement this? I hope this adds a little bit to your comfort levels, or how you think about things. This was overall an amazing experience for both of us, I think. And yeah, thank you, Josh, for having me here.
Oh yeah, no problem. Okay,
Yeah,
well, until next time. Thanks, Ani, and
yeah,
I'll talk to you again soon.
yeah. Thank you, Josh. Take care. Bye
All right,
bye.
bye.